Well, good afternoon or good morning or what are we doing here? Yes, almost afternoon. But so my job is to talk about critically evaluating this. And Richard asked me to do this topic, so I'm not going to have any sexy videos. I'm going to kind of prompt us to think about, should we be doing it, or how do we drive society and specialty in medicine to embrace this better? So I'm going to try and leave some time for questions. Not advancing, John. Let's see. How were you advancing it? Like that? Let's see. I give up, John, your computer.
Hitting the arrow to the right? Yeah, at first it didn't connect for me, and then it took a second.
It's not. There we go.
Is it advancing there?
It's advancing here.
Yeah, I know, and it wasn't advancing there.
And thank you for bearing with the technology challenges. Okay.
Mine did that at first too. Hold on.
Can I just...
Yeah, it's advancing up here, but it's not advancing there.
Okay, I can just switch over to this one.
You want to switch over to the one you have?
No, I can do it from
You can advance it. So the question is, what should we critically evaluate, right? And as you can see, the way I'm thinking about what we can critically evaluate or what should we critically evaluate with office-based procedures, well, there's feasibility. Can we do it? Well, you just saw from Drs. Wong and Delgadio, we can do it. What about safety and complications profile? You'll see, I'll review a little tiny bit of data, but generally I think there isn't a great deal of debate. Yeah, we can do it safely. The complication profile isn't radically different, so that's okay. Then there's clinical outcomes, which there's very little of, and I'll go into that. And then for me, and I think most of us, and looking forward, this is the more interesting question. What is the value proposition to the providers, to the patient, to society, and to healthcare? So let's go into a little bit of background. I'm going to race through this. You now know we can do a lot of things, and that's what you heard from Peter and John. Largely, to date, it's been trying to move what we do in the operating room to the office, with very little transformative procedures unique to the office. But that's probably what's coming in the therapeutic, drug-eluting stents and other topical deliveries, things like that. So there's a lot we can do, including stents and polypectomy, like you've seen from John and Peter already. But what are the challenges? So from a US standpoint, of course, we're US surgeons, and we have Poland, Finland, UK, what did I miss? Saudi Arabia.
Norway.
So I don't pretend to be an expert in healthcare delivery in all those countries in different parts of the world. So you understand the bias and experience here. But in the US, we've been talking about this for 10 to 15 years plus, this office-based rhinology. And it really hasn't materialized much, quite frankly. It's still a slow-moving, slow-to-adopt reality. Why is that? Some of the reasons why: limited skill set and expertise. What you just saw were incredible experts who've done this, worked at, and committed to it, right? Makes it really easy to do. It's not. Working around the patient, managing the patient in the awake environment, as you know who've tried it, it's hard, it's difficult. And then in the US anyway, we really haven't come up with a great way to scale this up, meaning how do we train more people to do this? General practitioners who don't do a lot of rhinology but do enough. How do we train them? How do we disseminate the expertise, the workflow in the office, etc.? And then we certainly don't have the economic incentive figured out in our country yet. And I'll go through this a little bit. Why do this? Right? And again, I'm not an expert, but for example, my understanding in Germany, it's still you're incentivized to keep patients in the hospital after rhinologic procedures, for example. And then the effective treatment is lacking. That gets back to, well, we can maybe do turbinates well, maybe we can do polyps well, but do we have a comprehensive approach to chronic sinusitis in the office that would really drive work in the office? And just some examples here when you look at adoption in the US. You talk about balloon procedures, inferior turbinate procedures, and stents. The vast majority are still done outside the office. 10 and 15 years after this conversation, some of these technologies are newer, obviously, but we're still doing them in the OR. So we haven't really moved the needle there. Global challenges. Lots of different challenges that are unique to each of you and where you practice. Variations in funding and support, private, public, insurance, etc. Lack of economic incentive, just like I outlined in the US. How are you incentivized to do this or not? Technical resources, population size, the epidemiology of the sinus disease you deal with in your region. Those are all drivers, right? Those are all realities of this. And this is one example that came from a publication recently. And this may be inaccurate, it's 2015 data, but this basically suggests a little less than 50% of the rhinologic cases in the country of France are performed on a daycare basis. So that's still in the operating room, but outpatient. In the US, that number is 80, 90, 95% at least are being done at least in an ambulatory setting. So just show you some different challenges. But these are the opportunities, right? And both John and Peter alluded to this: patient convenience, cost savings. These should be instinctive and intuitive, right? But do we know this to be true? And that's really part of this critical evaluation. Provider experience is important. Efficiency, does it make you more efficient or does it make you less efficient? Workflow in your office and equipment, et cetera. And then, of course, meeting OR utilization and capacity constraints that certainly in the US we're facing. So back to if in Europe septoplasties and routine festas are staying overnight, what's happening in our world in the US, the insurance companies are moving them off of our campuses to strictly ambulatory surgeries. For example, we're going to be told that we can't do routine maxillary antrostomies in a hospital setting, for example. That's coming in our world, just to give you an idea how you're going to drive that. Clinical outcomes. There's basically none looking at office-based procedures. This is a study that came out of a group in Canada that looked at their significant experience with office-based procedures, and what they're really doing here, they looked at procedures they would otherwise do in the operating room. So not simple polypectomies or stent placements or post-op debridements. They're talking about fast septum, septal rhinoplasties, things like that. And you can see the breakdown in the data here. Their point was to look at tolerance, how the patients do, and develop some sort of complication profile, some sort of understanding. Is it safe? Can we do it? So not true clinical outcomes with quality of life measures. And in the red there, you see for the sinus group, and they're doing full sphenoethmoidectomy, frontal work, maxillary work, with or without septal work, 6% complication rate with a post-op complication rate of about 2.5. And most of the intraoperative complications were pain. In fact, 4 or 5 of those patients had to stop because of pain in the office. Okay, so that was the intraoperative complication. And the overall complication rate you can see there. So they showed you can do a lot, just like you saw from Peter and John in the office. Patients generally do okay and tolerate it. That's all we have for clinical outcomes of relevance, really, on this. Now, costs. So as we talk about the financial analysis and the value proposition, once again, the value propositions for everybody involved. You, the provider, your staff, your patient, and whatever system you work within. Academic medical center, private practice, government-based, etc. How do we define direct and indirect costs? Surgical fees, facility fees, anesthesia charges are pretty easy to get your arms, at least for us, to get our arms around. The indirect costs are what's not really being talked about too much, though we speculate, right? So what does it mean to the patient, patient's family? Do we think about that? Lost productivity, the patient brings the patient to the operating room, takes him home, sits with them, etc. So this indirect cost is where there's huge opportunity, but we really don't know much about that data. So if we're going to value this, we have to understand that. So this is a study John was a part of, and he can comment on this later if we have a little bit of time, that tried to look at cost with office-based procedures. Now this is an older study, You can see the procedures were done in the time frame of 2006 through 2011. In the US, John has a clinic-based approach, a non-hospital facility-based approach that changes, but they looked at charges. They were trying to just get a handle on what were the charges, and they saw a difference or savings in charges for episode of care between $3,000 and $5,000 per patient. And they had some interesting conclusions here that favors an an office-based approach. They talked about similar reimbursement in the office versus the OR. Again, US we're talking about. This is important because in the laryngology world, which has been worked out a little bit in the US, costs tend to be a little more shifted to the provider, a little more expensive for the provider to do it. Cost savings for the system in some laryngology procedures, vocal fold injection and those types of things. And John and his group made a comment about disposables, and this is an older study, so we now have more and more disposables, stents, and things like that, which absolutely impact the cost calculus in the office. That's about all we have on specific cost analysis to date for office-based work. Stepping back, there is some productivity data out there. Sinusitis, big hit to productivity in the United States. If you try and break it down by some diseases, give or take $10,000 per year productivity costs in someone who's being treated for recalcitrant or difficult to control sinusitis. Those are big numbers. So it further helps us focus on we need to think about ways to trim these costs, and maybe office space is approached a way to do that. Then where are the incentives? So this is US data. It's a very busy slide. I want you to focus really right here. So these were just recently changed and updated. These are the balloon codes. And you can see what the US has tried to do as far as putting incentives to drive more work to the outpatient or the office setting by changing reimbursement for physician office versus facility. And you can see a significant difference in dollars of reimbursement. There's a lot of complexities that go into this. Costs of device are built in for the office, et cetera. But you can see initial moves to try and move to the office some of these procedures. But what are the incentives elsewhere in the world, in the country? That's going to be really unique to your world. So back to this slide. Same set of opportunities. But we need to solve all of this and define all of this if we're really going to try and justify and move this to the office, many of these procedures. So a snapshot of kind of summary in my thinking of where we stand on critically evaluating this. Rigorous data is lacking. Interest remains strong, and by that I mean, I think providers, we want to see this happen intelligently. Our industry partners want to see this happen efficiently. And in the US anyway, there's a huge push towards cost savings from government and private insurers. So interest remains strong. But we need to define how to do this safely, in an efficient manner, and how to scale it up broadly, back to expertise and training people who do common rhinologic procedures that are comfortable doing this, right? Economic impact is important, and as I've said over and over, the solutions and answers to these problems are going to be unique to where each of you practices in each country and healthcare system, which certainly in the US anyway is changing almost on a yearly basis. So, Richard, I tried to leave you 5 minutes. Sorry for the rushed presentation, but hopefully it gives you something to chew on a little bit.